Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. I'm Abdulrahman Farahat. I'm a fourth year medical student. And before we begin, كل عام وانتم بخير, Ramadan Kareem Ya Rab. I hope your studies are going well. Our discussion for today is going to be liver and biliary disorders. Inshallah, it's going to be covering all the lectures, speaking about the liver and the biliary disorders, inshallah. Here's my contact details. If you have any questions, please feel free to text me whenever you want. And we can begin. Just get my pen really quickly. Before we begin, I wanted to take a look at the basics of the liver anatomy and the physiology. I feel like it's going to be very important to understand them before we actually get deeper into the different pathologies. Starting really quickly with the anatomy of the liver. As we all know, the liver is made up of four lobes, a right and a left lobe, and then there are two other lobes, the caudate and the quadrate lobe at the back. Regarding the ligaments, what I want you guys to focus on is the hepatoduodenal ligament, and from its name, it connects the liver to the duodenum or the small intestine. And the significance of it is that it contains your portal tract, the portal vein, your hepatic artery, and then your common bile duct. Yeah, that's the significance of the hepatoduodenal. Now, moving on to the blood supply of the liver. The liver is supplied by dual blood supply. The portal vein, some lectures said 70%, keep it as a range from 70 to 80% by the portal vein and 20 to 30% by the hepatic artery. Right, so where does the portal vein and hepatic artery come from? The portal vein comes from joining of the superior mesenteric vein and the splenic vein. If you could imagine with me, here's the spleen. It sends a vein like this, and then you have the superior mesenteric vein. They join together, and then you get your portal vein going to the liver. Now, on the other hand, you have your hepatic artery, which comes from the it comes from the celiac artery. So the celiac artery gives three main branches. One of them would be the common hepatic artery. The common hepatic divides, it gives two other branches. One is the proper hepatic, and the proper hepatic then divides into the right and left and the cystic arteries. Now, regarding the drainage of the liver, it's through the hepatic vein, which drains directly into the IVC. So the hepatic vein comes like this, and it drains into the IVC. Okay? Right. Now, a quick talk regarding the portosystemic shunts. We already mentioned how all your all your GI organs are drained directly either into your portal vein, your splenic vein, or your superior mesenteric vein. Okay? But some of those veins actually have certain communication with other systemic veins. For example, you have your left gastric vein, which drains into your portal circulation, is connected to your azygous vein. Similarly, you have your paraumbilical vein, which drains into the portal circulation. It's connected to your small epigastric vein, draining into your systemic circulation or directly into your IVC. Finally, you have your superior rectal vein draining into the portal circulation. It's connected to your middle and inferior rectal veins. Now, this is important when it comes to certain pathologies, most notably the portal hypertension. And essentially what happens is, I'm sure you guys know this, when there is portal hypertension, there is increased flow through the portal circulation in general, and this could lead to backup of flow into the left gastric vein, the paraumbilical vein, and superior rectal vein. And a rule of thumb is the blood tends to flow from regions of high pressure to low pressure. Because there is high pressure in those left gastric vein, the paraumbilical veins and the superior rectal veins, they start to look for other connections that they could go through. And this happens by connecting to the azygous vein, and this would lead to certain pathologies such as esophageal varices. Paraumbilical would drain into the small epigastric vein, leading to caput medusae. And finally, you have the superior rectal draining into the middle and inferior rectal, which could develop as an internal hemorrhoids. Okay? Right. Now, regarding the histology, the liver is sort of divided into or composed of hexagonally arranged structure that are divided into zones. So you have zone 1 over here, and then you have zone 2 in the middle, and zone 3 in the exact center of it. 1, 2, and 3. Zone 1 is closest, as you can see, to the hepatic artery, your portal vein, and your bile canaliculi. And so it's closest to the blood supply, and it has the lowest cytochrome P450 concentration. On the other hand, zone 3, it's the furthest from the blood supply and has the highest cytochrome P450. Now, why is this important? It's important when it comes to certain scenarios. So for example, over here, let's say the patient presents with ischemia, which is organ hyperperfusion, for some reason or another. You could get asked which zone is affected first. But in ischemia, you would expect that the zone furthest from the blood supply would be affected first. And this is why in ischemia, it's said to be zone 3 that's affected first. Now, similarly, you have acetaminophen and alcohol toxicity. Now, those substances are both metabolized using the cytochrome P450 system. Right? But again, you think about it, which zone has the highest cytochrome P450? Now, those, before we actually get into it, really quickly, the substances that result from the metabolism of acetaminophen and alcohol are both toxic substances. Acetaminophen would produce toxic substances after it gets metabolized, and alcohol would do the same thing. This is why you try to limit, or for you, it's better to limit the metabolism of those substances. When it comes again back to the zones, but you take a look at the zone that has the highest cytochrome P450, and this means it's going to metabolize those metabolites into more toxic substances more. But this is why, again, in zone 3, you'd have the first damage when it comes to acetaminophen or alcohol toxicity. Viral hepatitis, you guys don't have to remember for now. Again, this is similarly to what you already have discussed already. Okay? Now, I saw this diagram in one of your biochemistry slides. All I need you to know is basically this point. Lower closest to the blood supply is zone 1, and then highest cytochrome P450 is at zone 3. You probably won't get asked about the rest, inshallah. Right. Now, regarding the cells and their functions inside your liver, you have 3 main cells you have to keep in mind. You have your hepatocytes, your Kupffer cells, and your hepatic stellate cells. Your hepatocytes essentially, from its name, hepatocyte, they are your liver cell, and they cover the majority of this organization over here, and they also line your bile canaliculi, so over here in that region. And what they do is they synthesize your bile, they do your metabolism, and they secrete it. And flow is like this. Okay? Now, then you have your Kupffer cells. Kupffer cells is just another name for macrophages found in the liver. Simple. Then you have your hepatic stellate cells. Hepatic stellate cells are cells found in this. So imagine here's your portal tride, here's your portal vein going like this. Here's your hepatic artery joining your portal vein, forming the sinusoid. And then you have your bile canaliculi. Bile flows like this outside of the liver. And in between them, here's your endothelium, and here's your hepatocyte. There's a space. This space is called the space of DC, where you'd find those hepatic stellate cells or your HO cells. And they function by storing vitamin A, and they are important for fibrosis. Right? Remember them, because we're going to have a good talk about them when it comes to cirrhosis. Right. Then finally, regarding metabolism, try to understand it rather than memorizing it. I made like a quick mnemonic. The liver is a FADS. F for factory. It synthesizes a lot of your fatty acids, your ketone, your protein, which is important for proteins such as albumin. It synthesizes bile, as we all know, cholesterol, and clotting factors. And A is for altering nutrients. It alters your glycogen, your gluconeogenesis. It's important for your urea cycle and for your lipid metabolism. D is for detoxification using the cytochrome P450. And it's important for vitamin D hydroxylation. Okay? Finally, it stores your iron, your copper, which are important in certain diseases such as Wilson and hemochromatosis, your vitamins B9, B12, your fat-soluble vitamins, and glycogen. And like, now, quickly regarding the biliary tree, its anatomy is pretty straightforward. You have your right hepatic duct over here, and then you have your left hepatic duct. They join, they form the common hepatic duct. And then the cystic duct joins with the common hepatic duct, giving your common bile duct. And then at the end over here, you have your pancreatic duct joining both, and they open at the ampulla of water. Okay? Like, an important thing to keep in mind is the double duct sign and Courvoisier sign. The double duct sign essentially is when they take a certain image, mainly an MRI or a CT, and you can see over here that there is dilation of the common bile duct and dilation of the pancreatic duct. This is essentially what double duct means. And it signifies an obstruction where at the ampulla of water over here. The double duct sign is an important marker for gallstone obstruction at the ampulla of water. Right. Then you have your Courvoisier sign. Courvoisier sign essentially means you have an enlarged gallbladder that could be palpated, plus painless jaundice. Like once you see painless in anything, one of the biggest differentials that should come to mind is a malignancy or a tumor. This is why Courvoisier sign is very important, because it signifies a malignancy. There is an obstruction by an enlarged gallbladder, and it is painless. So you'd have to think about malignancy. The two most common causes would probably be a pancreatic adenocarcinoma or a cholangiocarcinoma. We're going to talk about this one at the end, inshallah. Right. Now, quickly regarding bile. So bile consists of 6 things: bile acids, your bilirubin, your cholesterol, your phospholipids, water, and ions. Now, as you can see, I've marked those 3 specifically because you need to understand that those are the main things that control your gallstone formation. Any imbalance in any of those 3 would lead to gallstone formation. So you have 2 types of gallstone. You either have a cholesterol gallstone or a pigmented gallstone. Your cholesterol gallstone, from its name, you have much more cholesterol than the others. So cholesterol will be high. Then you have your pigmented gallstone. That's where you have bilirubin. Bilirubin is mainly higher than the other 2. Now onto the functions of bile. So as you all know, bile is really important when it comes to digestion of your fats and helps for absorption of your fat-soluble vitamins, A, D, E, and K. Bile is also really important because bile itself, bilirubin itself, is very toxic to the body. But the body, it's a mean for the body to excrete this toxic substance. And finally, for its antimicrobial activity, and we're going to talk about it, inshallah, at the end when we discuss acute cholangitis. Okay? Here's a quick schematic of how essentially bilirubin moves through your body. Really quickly, you have your RBC over here. It gets broken down. You have your heme molecule. Heme molecule gets or forms your unconjugated bilirubin, which gets absorbed into the liver. Unconjugated bilirubin undergoes conjugation using an enzyme called UDP, glucuronidase transferase, which is important to remember. Then it gets excreted into bile. Now, once it reaches your small intestine, there are 2 pathways. Either it gets excreted, which is the main majority, or 20% of it would get absorbed. 90% of those 20% will go back to the liver for recycling and reuse, and 10% will be excreted in the urine. Quick talk regarding certain conditions where you have inability to absorb fats. But there are certain conditions such as short bowel syndrome and Crohn's disease where you have an abnormality in absorbing fat. So really quick talk regarding bile absorption and the enterohepatic circulation. For already mentioned, bile, a percentage of it gets recycled back to the liver. But there are certain conditions where this pathway is effective. Usually bile gets absorbed at the terminal ileum, and certain conditions such as the short bowel syndrome and Crohn's disease, where there is a problem in your terminal ileum, you are unable to absorb the bile. So this shows actually on examination by having decreased fat absorption as well, because as we all know, bile is very important for fat absorption. But if you're unable to absorb bile, fat would start accumulating more inside the intestine. Now, why is this important? This is important when it comes to another molecule or another ion that comes into play, which is your calcium ions. Calcium typically binds to what? Typically binds to another molecule called oxalate. So calcium binds oxalate, and they are excreted together. Now, in this scenario where you have too much fat in your intestines, calcium actually preferentially binds to your fat. And now oxalate is free to roam around inside your intestine. And once oxalate is free, it could get easily absorbed by the body into the blood. And this is why those patients are at an increased risk of forming what we call calcium oxalate kidney stones. Okay? So this is basically everything that is found over here. Decreased absorption of enteric bile salts at distal ileum, is as in short bowel syndrome and Crohn's disease, prevents normal fat absorption and may cause bile acid diarrhea. Now, this is important when it comes to calcium, which normally binds oxalate. It binds fat instead. So free oxalate is absorbed by your gut, and this increases the frequency of your calcium oxalate kidney stones. Okay? Fine. Now, let's begin our journey with liver pathologies. Before we get into the actual pathologies, let's take a look at liver function tests. I divided it into 4 things: your transaminases, alkaline phosphatases, and GGT, prothrombin and albumin, and then you have bilirubin. Okay? For the transaminases, always remember alanine transaminase is more specific, more sensitive, and usually higher in liver disorders compared to aspartate transaminase, except in alcohol liver disease. In alcohol liver disease, you have twice as much aspartate than alanine. And this is one thing you need to remember. Secondly, you need to remember the degrees of elevation. This is, and it seemed when we were studying it last year, it was not that important, but it is actually very high yield, and we got asked about it. But try to remember the degrees of elevation, and it's essentially referring to in what condition or how much does your transaminases increase in said condition. Okay? But you have 4 categories: either mild, moderate, severe, or massive. Mild is less than 300, and it's found in chronic diseases. Chronic means in whole it's taking a long period of time, and it's slowly killing your hepatocytes. But typically, you'd have a lower number of transaminases than other conditions. Examples of this would be Wilson, hemochromatosis, alcoholic. Anything chronic would kill your hepatocyte on a longer period. Fine. Then you have your moderate increases from 300 to 1,000. Remember, active inflammation, specifically viral or autoimmune. Fine. Then you have your severe, which is severe disease or very acute. So it's killing your hepatocytes rapidly right now. So you typically expect much greater increases in your transaminases that could reach up to 1,000. But in severe diseases, you should always remember ischemia, acetaminophen toxicity, and again, severe acute viral hepatitis. But if you can see, viral hepatitis could range from 300 up to 1,000, could be more than 1,000. If I remember correctly, we got asked about acute viral hepatitis, but remember that range. Then you have for massive, again, massive overdose and ischemia. Now, this actually comes from this table over here. I simplified it much more to this. Right? Then you have your alkaline phosphatase and GGT. Always remember, alkaline phosphatase is a very non-specific enzyme. It could be raised in other conditions affecting your bone. It could be raised in pregnant patients, but it's not specific. This is why you always have GGT with it. What does GGT do? Essentially, you're measuring your alkaline phosphatase. If it's elevated, you take a look at GGT. If GGT is normal, then it's a non-hepatic cause. If GGT is increased as well, then this would signify in wallah, this is a hepatic, like hepatic origin. Right? Another thing is your R factor. R factor, there is a much more sophisticated equation than this. As to put it in simple terms, you have your alanine transaminase over your alkaline phosphatase. And always remember that the more alanine there is, it's probably a hepatocellular cause. And the more alkaline it is, if alkaline is more than alanine, then it's a cholestatic cause. This is essentially the R factor. If it's more than 5, then it's hepatocellular. This means alanine is greater. If it's less than 2, then it is cholestatic. This means alkaline is much greater than your alanine. Hello. I also mentioned here, if it's hepatocellular, you can do more blood tests. If it's cholestatic, you go directly to ultrasound. Like, one last thing is prothrombin and albumin. If you guys remember, we already spoke about how the liver synthesizes a lot of your important molecules, including your Clotting factors, that's one, and proteins, that's two, your albumin. If there is liver damage, you could think about it. Well, liver damage, so you won't have clotting factors that are important for clotting. Your prothrombin time or your bleeding time would increase. And so this is one. Secondly, you have albumin. If the liver is not synthesizing enough albumin, you'd have low albumin levels, and this could predispose to some conditions, including ascites. And we're going to have a good talk, inshallah, on it. Then you have bilirubin. So bilirubin, hyperbilirubinemia in general. If there is liver injury, of course, you're going to have difficulty in metabolizing bilirubin. However, hyperbilirubinemia itself could be categorized into three causes, either a prehepatic cause, a hepatic cause, or a post-hepatic cause. A prehepatic cause of bilirubin is regular RBC hemolysis. If you have hemolysis of RBCs, you typically have high unconjugated bilirubin because it's a lot of bilirubin spilling into the blood before reaching the liver. It does not get conjugated. Secondly, you have your hepatic causes, which we can divide it into either hereditary causes or hepatocellular injury. And it could be either conjugated or unconjugated because it's within the liver, depending on where exactly it affects or where exactly the disease process is, it could be conjugated or unconjugated. Then you have your post-hepatic cause, which is basically after you have conjugated your bilirubin, you're unable to excrete it, and this is typically due to an obstruction either by gallstone or tumor, and it's typically a conjugated or an increase in conjugated bilirubin. Like, now, regarding hereditary hyperbilirubinemias, you guys need to remember three conditions that were discussed in your biochemistry lectures. They are all autosomal recessive conditions. And again, if you go back to our amazing diagram over here, hemoglobin gets breaking down, gives you unconjugated bilirubin that gets absorbed. This unconjugated bilirubin gets conjugated using an enzyme called UDP glucuronidase transferase. And then the conjugated bilirubin is excreted into the bile canaliculi using a specific transporter over here. But if you have a deficiency in UDP glucuronidase transferase, this gives you two conditions, depending on the severity. If there is complete absence of UDP glucuronidase transferase, this is referred to as Crigler-Najjar syndrome. If there is mild decrease in your UDP glucuronidase transferase, then this is Gilbert syndrome. This is how you can differentiate between them. And if you think about it, since Crigler-Najjar, you have complete absence, it typically presents way earlier onset than Gilbert syndrome. So it typically happens in children. There are two types of Crigler-Najjar, type 1 and type 2. Type 1 is typically more severe and it needs rapid action, including liver transplantation, phototherapy, so on. While type 2, you could just give phenobarbital. Now, on the other hand, you have Gilbert syndrome. As you mentioned, it is mild decrease. It would typically happen over a longer period, and the onset is typically at around 19 to 20 years old. What causes it is periods of stress or periods of fasting, all of those which lead to the symptoms of hyperbilirubinemia, jaundice, and so on. But you got your unconjugated bilirubin, it became conjugated, and now we mentioned over here that it gets excreted into your bile canaliculi using a transporter. Now let's say you have a deficiency in this transporter. There is no transporter. This conjugated bilirubin would start piling up and its levels would increase. This is the condition referred to as Dubin-Johnson syndrome, and you have a mutation against a multi-drug resistant associated protein, which is this protein over here. And you're unable to release your conjugated bilirubin into your bile canaliculi. It is typically characterized as well by a dark liver because of the conjugated bilirubin piling up. Now, if you take this one step further, we mentioned in the Dubin-Johnson is a problem with bilirubin excretion. And if we go back to what we already discussed regarding bile constituents, we said in the bile is made up of bile acids, bilirubin, cholesterol, phospholipids, water, and ions. Let's say you have a problem with bile acid excretion. This would predispose to two other conditions mentioned in your biochemistry lectures, the progressive familial intrahepatic cholestasis and the benign recurrent intrahepatic cholestasis. And to quickly differentiate between them, Progressive familial essentially means you're continuously unable to excrete your bile acids. So it's much severer than your benign recurrent. Recurrent essentially means that it comes and goes. Okay? This is the problem with bile acid excretion. And if you want to think about the symptoms, you have inability to form proper bile because lack of bile acid. This would predispose the patient to inability to absorb fats, absorb fat-soluble vitamins. And since they are not able to excrete bile acids itself, bile acid would start accumulating in the body. And this would lead to other symptoms such as itching or pruritus. Right? Now, this is done with the, let's say, the boring parts of the biochemistry lectures. Now let's move on to actual pathology, starting with liver cirrhosis. So liver cirrhosis is a condition that develops as a result of chronic inflammation and hepatocellular damage. Right? And there are many causes that, inshallah, we're going to get through all of them by the end of this session. It could be viral, autoimmune, alcohol. The main point is that there is very chronic inflammation, and this would lead to hepatocellular damage. You have hepatocellular damage. What would happen? Hepatocytes would start releasing certain signals, certain molecules, and they start stimulating Kupffer cells. Then the Kupffer cells and the hepatocytes again start releasing other signals, and mainly start thinking about TGF-beta. This cytokine goes and it stimulates your stellate cells. If you remember, stellate cells were found in your space of DC, and they are important in vitamin A storage as well as fibrosis. But once you stimulate your stellate cells, you start your fibrosis, and this is the next pathway over here. You have fibrosis in your perisinusoidal space. Right? Is that it? No. Another ability of hepatocytes is its ability to regenerate. If you have hepatocytic damage, the hepatocyte cell itself is able to regenerate and grow again. This is where you have regeneration capacity of your hepatocytes. Now, both of those together will get you your bridging fibrosis and your regenerative nodules. Is this it? No. The pathology goes a little deeper. When it comes to liver dysfunction. So why is there liver dysfunction in cirrhosis? This happens because of two things. But let's simplify it and go back to the origins again. What's the main function of the liver? The liver is important for fats, essentially fats for metabolizing substances, detoxifying the body, forming certain molecules, and so on and so forth. So how does cirrhosis prevent this? It prevents it through two mechanisms. First, you have liver dysfunction due to the hepatocellular death itself. So the cells inside the liver already are weak and they start dying, so they won't be able to function properly. That's one. Secondly, because of all the cirrhosis, there is fibrosis that leads to vascular changes as well. So what are the vascular changes that we need to think about? First is the loss of sinusoidal fenestrations. If you can go back to our diagram over here. Yes, so let me just delete it. Erase one. You can see over here, again, you have your portal vein and then your hepatic artery, they drain and they form your sinusoid. Now, across this sinusoid, the walls of the sinusoid is fenestrated, so it's open. So molecules, toxic molecules can escape this sinusoid. And where will it go? It would go to the hepatocyte. It would get absorbed by the hepatocyte, and the hepatocyte does its function and metabolizes those substances. Right? Now, because of the fibrosis typically around this area right here, and this area around here as well, those fenestrations block off. And now the toxic substances are unable to escape your sinusoid, and they continue straight into your central vein. So the liver does not, even if the liver is normal, it will not receive any of those metabolites to work on. Right? So this is one reason. Secondly, this is also referred to as a portal hepatic vein shunt, because of the fibrosis, instead of the normal pathway of the metabolites going in, get metabolized by the hepatocyte and stuff, no, they shunt directly into your hepatic vein and to your systemic systemic venous system. Okay? All right. Well, those are the two reasons why there is liver dysfunction. One, we said because of hepatocellular death. Two, because blood bypasses liver cells and there is poor detoxification. Like, we're going to talk about the complications of poor detoxification later, inshallah. Like, now over here, you can see an image of a normal liver. You have your portal triad and then zone 1, 2, and 3. And here is your central vein. Over here on your right side, it's liver cirrhosis. You can see your bridging fibrosis. Here's your fibrosis. And inside of it, this is your regenerating nodule, or the restoring or regenerative capacity of your hepatitis. Now, we need to differentiate between two concepts, which are compensated and decompensated cirrhosis. Compensated cirrhosis, just remember, and there are no systemic signs. There are no signs of jaundice, there is no ascites, no complications of cirrhosis, nothing. Best, there are skin manifestations. There are skin manifestations such as pulmonary edema, spider angiomas. Secondly, remember to differentiate between varices and variceal bleeding. If there is varices, that's still compensated. If there is bleeding, that's when you categorize the patient as decompensated. طبعا portal hypertension as well. If there is portal hypertension, that's the cause of the varices. Again, it is compensated. Right? The main thing you have to remember is no systemic signs in your cirrhosis, while there are systemic signs in decompensated cirrhosis. Okay? Now, cirrhosis leads the discussion to portal hypertension. Portal hypertension could be caused by three causes. One of them we were talking about, which is cirrhosis. And this happens because of your extensive fibrosis around the sinusoids. And so the intrahepatic sinusoids no longer have the ability to actually comply with the blood flow, and blood would start piling up, leading to your hypertension. But over here, you can see, because of the extensive fibrosis cirrhosis causes, there is decreased vascular compliance, or the capacity of the blood vessels to actually accommodate for blood inside of it. And this specifically happens in your intrahepatic sinusoid and your portal veins. Okay. So this is one cause of portal hypertension. Now, before we get into the other complications of portal hypertension, let's talk about the other two causes of portal hypertension, which are prehepatic causes, mainly portal vein thrombosis, and post-hepatic causes, which are hepatic vein thrombosis. But from its name, portal vein thrombosis, imagine you have the portal vein like this, and you have a thrombus that, even if it does not fully occlude your portal vein, it's just there. You can see no blood flow would be difficult to pass through this tight opening over here. But again, it would lead to portal hypertension. Now, this is the most common event in cirrhosis. And how we would diagnose this is typically you do an ultrasound. And using an ultrasound, you'd find in Wallah there is there is no blood flow assessment post that thrombosis. So you start suspecting portal vein thrombosis. That's why you have to confirm it using a CT scan or an MRI, usually a contrast CT scan or an MRI. And how would you manage those patients? You'd manage the thrombosis like any other thrombosis in the body. You give the patient anticoagulants. Usually for acute, you'd start with low molecular weight heparin, and then for longer term, you'd give oral anticoagulants such as warfarin. Okay? Over here, you can see endoscopy screening. Now, this is important not only for portal vein thrombosis, but generally for any portal hypertension patients. And it's important to for screening of esophageal varices. And it's done usually at 1 month and then 1 year. Then you have your post-hepatic causes. Post-hepatic causes, you have to remember, there is a single cause you have to remember, which is Budd-Chiari syndrome. Now, Budd-Chiari syndrome on its own happens because of other causes. And it essentially refers to hepatic venous outflow obstruction. But let's draw a liver right here. Okay. And then you have your hepatic vein exiting the liver. Now there is an inability of that hepatic vein to remove the blood out of the liver. So this is what we refer to as a hepatic venous outflow obstruction. It happens in Budd-Chiari syndrome. What are the causes of Budd-Chiari syndrome? There are multiple things you have to think about. Myeloproliferative disorders is one, but if you remember from heme, you have either polycythemia, which is increased RBC volume, or increased hemoglobin to be exact, and this could lead to viscous blood. And viscous blood means, again, blood would start congesting over here, and it's going to be difficult to drain your liver. Another thing is thrombocythemia. thrombocythemia is increased platelet count, and so the more platelets means more clotting and thrombosis. Other causes such as thrombophilic disorders, hormonal intake such as oral contraceptives, and other. So these are the causes of Budd-Chiari syndrome. How would you diagnose it? Again, using ultrasound. And for management, you'd start low molecular weight heparin, and then depending on the cause, you treat that cause. Hello. Now, let's move the discussion to the complications of portal hypertension. Now, there are much more complications than this, but I chose a couple that I feel are the highest of yield. Starting with ascites. Ascites, as we all know, it is increased fluid in your peritoneal cavity. Fluid shouldn't be there, but if you have more fluid in your peritoneal cavity, that is referred to as ascites. And we're going to take a look at the pathogenesis in a bit. Then you have congestive splenomegaly. So again, imagine the liver like this, and you have the spleen over here. We said that you have your splenic vein, your superior mesenteric vein, both come and form your portal vein. But if you have portal hypertension, blood would start congesting back into the spleen, and this would lead splenomegaly. Now, again, it would congest back into all the GI organs, but this is why specifically it can cause splenomegaly. Right? Then you have portosystemic shunts, which we already discussed. So blood would, like we said, it would backflow into certain into the portosystemic shunts. So with the esophagus, it would form esophageal varices. With the paraumbilical, it would form the caput medusae, and with the superior rectal, it would form your internal hemorrhoids. Now, when it comes to esophageal varices, before we actually get into the management, there's a drug you can give to for prophylaxis or prevention of esophageal varices, and that's usually beta blockers. So always remember, you start them on non-selective beta blockers, and this could cause or could prevent formation of esophageal varices. But let's say this patient now developed varices, what can you do? You do Variceal, which is a Saraha mnemonic I got from your lectures, but it does the job. V is for volume resuscitation because they are losing blood. Antibiotics because their blood is exposed, there is bleeding, and there is exposure to outside organs or the outside environment. You have to start them on antibiotics. Then you reach for an esophagogastroduodenal endoscope and do band ligation. Now, band ligation is very high yield to remember because it is the gold standard for management of those varices. Then you infuse octreotide, which is a somatostatin analog, and it causes vasoconstriction, so it reduces your portal hypertension complications. Then you have coagulation correction. So again, because there is bleeding, you need to prevent the bleeding. Finally, encephalopathy prophylaxis, and we're going to take a look at hepatic encephalopathy and why it happens essentially. Right. Now, for portal hypertension, we already mentioned how it causes ascites. So regarding ascites, we said it is fluid in your peritoneal cavity. So this is a lot of fluid building up in your peritoneal cavity. Now, why exactly it happens? First of all, we mentioned how you have, if we go back to this diagram, we said you have your splenic vein, your superior mesenteric vein, they join forming your portal vein. And when there is hypertension, blood would start pulling back and filling the other veins in the body. So we said how when it fills your splenic vein, it could cause congestive splenomegaly. It could go back to your superior mesenteric vein and actually dilate the blood vessels, the veins draining your small intestines or the superior mesenteric vein tributaries, all of it. But those blood vessels would start dilating. Now, a way I'd like to think about it is whenever you have increased flow or increased liquid in anywhere, this is a predisposition to bacterial overgrowth. So what happens after it is you actually have something we refer to as bacterial translocation. So bacteria would start growing in that area, entering into the lymphatics, entering into the dilated blood vessels. And once you have bacteria entering there, the body has an immune response to it. The body starts attacking the bacteria. The body's immune response typically would include neutrophils. It will get your white blood cells and so on. But it also starts releasing cytokines and other molecules. Particularly, it's important to remember it releases nitric oxide. So what does nitric oxide do? It causes even further vasodilation. Right? But now you have a lot of vasodilation happening in that region. There is much more flow happening in that region, and that's where you can see over here, I've written down there is increased hydrostatic pressure. So if we go back to our basics of physiology, if there is increased hydrostatic pressure, you'd have more fluid filtration into the surrounding organs, and this can lead to, or this is the basis of ascites. Okay? طيب. Now, SAG, honestly, I do not know the exact or what it exactly stands for, but I need you guys to remember two values. If it's more than 11, if the SAG is more than 11 or 1.1, then this ascites is caused by portal hypertension. If SAG is less than 11 or less than 1.1, it's caused by any other cause. Right? Just keep it as simple as possible. Then you have the complications of ascites itself. Ascites may lead to two things, if you can remember: spontaneous bacterial peritonitis and hepatorenism. Spontaneous bacterial peritonitis, if we go back to our explanation, we already mentioned how, because of this fluid leakage, the more fluid there is, the more chance of bacteria actually growing on that fluid. This is where you can have spontaneous bacterial peritonitis, which is infecting your acidic fluid, right? And it's usually a gram-negative infection. طيب. Now for hepatorenal syndrome. Okay, so we already discussed spontaneous bacterial peritonitis. Now onto hepatorenal syndrome. So the concept again is you have this splanchnic vasodilation and there is blood leaking into your peritoneal cavity, and the body starts understanding this as, well, there is organ hyperperfusion. In response to that, the body starts activating your renin, angiotensin, aldosterone system from your kidneys. Normally, in a normal human body, the RAS system would cause vasoconstriction and it will control your blood pressure. But because in this condition you have a lot of splanchnic vasodilation because of your nitric oxide release, the renin angiotensin system would specifically work at your kidneys and it cause vasoconstriction at your kidneys. And this is why, over a longer period of time, there would be organ hyperperfusion, but to the kidneys only. And this is why you could lead to hepatorenal syndrome, which is essentially kidney failure. Right? Right. Moving on, we have portal hypertension and esophageal varices. We already discussed the mainstay treatment or the gold standard, which is band ligation. And we already mentioned how beta blockers are your prophylaxis. Now, in the scenario, there is refractory bleeding. So the patient underwent band ligation, and there was refractory bleeding. You can do something called transhepatic intrajugular portosystemic shunt. So this essentially means in Allah, you have your portal venous system, and you shunt it, instead of going through the liver over here, you shunt it to directly connect to your hepatic vein, like this. And as you could imagine, this would relieve your hypertension. Thus, it bypasses the liver and could lead to a lot of problems, such as hepatic encephalopathy. Now, this perfectly leads the discussion to what is hepatic encephalopathy. Hepatic encephalopathy arises when the blood starts bypassing your liver cells. And essentially, this would lead to poor detoxification or low metabolism of those toxic substances. And those toxic substances are now free to go to the rest of the body. Now, the main substance I want you guys to remember is ammonia. Ammonia starts accumulating, and it is pretty neurotoxic. Now, what would the patient present with? Typically, in the question stem, you'd find some sort of altered mental status, like dementia or something, and there would be asterisks. Asterisk is essentially flapping tremor. If you do like this, the patient will start having a flapping tremor. Finally, a deteriorating liver functions, and as we mentioned, you could take a look at their liver enzymes that be elevated. For all three found together in the same question stem, you'd have to think directly about hepatic encephalopathy. Now, there are certain exacerbating factors, and unfortunately, we got asked about one as well last year, and that would be azotemia or renal failure, and this would exacerbate your hepatic encephalopathy. Other causes would be sedative, GI bleeding, infections. So if you have to remember one, remember the most common, which is azotemia or renal failure. And now this has been for your hepatic encephalopathy. Now we could take a look at, okay, now for hepatitis, I need you guys to remember, as you know, hepatitis is inflammation of your hepatocytes. You'd have certain signs Of course, you'd have your elevated transaminases, you'd have jaundice, right upper quadrant pain. All of those are common when you have hepatocellular injury. Finally, you have your risk factors. Risk factors is essentially what's going to tell you whether this hepatitis is viral or autoimmune or alcoholic, so on and so forth. Right? Like, let's start with our first one, which is viral hepatitis. There are two types. You have either hepatotropic viruses or non-hepatotropic viruses. Hepatotropic viruses are viruses that go and infect specifically the liver, and those will be the main topic of our discussion. The other ones are viruses that are present that are such as CMV or EBV that are present in the body and could infect the liver. Right? Like, starting with hepatitis A. Hepatitis A, what you guys need to remember is that it is fecal-oral route. The route of transmission is fecal-oral. So because of contaminated food and so on, the most common scenario you'd find it in question stems is in cruise ships or someone that ate shellfish. So it's usually a party and people went there and they usually eat some sort of fish, right? And 2-3 weeks later, they started developing right upper quadrant pain, jaundice, elevated transaminases. You start thinking directly about hepatitis A. What exactly happens is that the virus enters into the hepatocyte. On its own, the virus is not toxic. It does nothing. But when it gets detected by the immune system, you have your CD8 positive cells that start killing your hepatocyte. How would you diagnose this? Typically an immunoglobulin IgM for hepatitis A virus antibody. How would you prevent it? Since it is fecal oral route for hygienic practices, and then immune serum immunoglobulins. You give this to patients who are, or people who are traveling to endemic areas or areas where you suspect they'd have hepatitis A. Hello. Now for management, let's say this patient is positive for hepatitis A virus. You give him two things. We refer to it as passive active immunity. And so the passive is through your immune serum immunoglobulins. So you'll just give them antibodies against hepatitis A virus directly through the blood, and then you vaccinate them as well. Right. For hepatitis B, now this one is the most common. The route of transmission is through body or bodily fluids. You need to think more about IV drug abuse, unprotected sexual intercourse, all of those. The course is is very acute, but thank God it's 90% of it actually does resolve. 10% could be chronic or silent. Now this hepatitis has an issue with that it integrates its viral genome, and this is why it actually could become chronic if it's not completely removed from the cell. Now, another thing, because it integrates its viral genome, it could possibly develop cancer. Now, on microscopy, you need to identify a couple of things. First of all, you need to identify those things over here, which are referred to as ground glass appearances. And then you also need to identify, here are a couple of balloon degenerations. And finally, those red color, you could say hyaline bodies over here, which are referred to as Councilman bodies. Right? How would you manage those patients? You'll vaccinate them. Right? Okay, so this is for hepatitis B. Very importantly, you guys need to identify whether this patient is infected, previously infected, vaccinated, acute or chronic, so on and so forth. But before we take a look at this, let me explain over here. But if you have the hepatitis B surface antigen, you take a look at it first. If it is positive, this means that the patient is currently infected. The virus is inside and the patient is infected. If it is negative, you could rule out the infection. Then you take a look at two things. First, you take a look at the surface, let me write surface, antibody. And then you take a look at the core, the C antibody as well. Right. Let's say this patient is hepatitis B surface antigen negative. This means, no, they are not infected. Thus, the surface antibody is positive. Surface antibody is positive, and the core antibody is negative. This means this patient has been vaccinated. Why? Because the vaccine of hepatitis B only consists of the surface antigen. If the patient gets exposed to the vaccine, they'd make antibodies against the surface only. They won't make antibodies against the core. If the surface is positive and the core is positive,
this means this patient has been previously infected. But because the surface antigen is negative, this means his infection has resolved. Like, another scenario is when the patient's surface antigen is positive. Right? Now, this patient is currently infected. How would you differentiate whether if it is an acute infection or a chronic infection? You take a look at the IgM antibodies. If the IgM are positive against hepatitis B, so that means it is an acute infection. You just recently got infected. If the IgM is negative, this means it's been a chronic infection and latent. Right? So this is the concept, basically everything over here. If surface antigen is negative and the antibodies are all negative, this is, again, of course, susceptible infection. If the surface antigen is negative, core is positive, surface is positive, antibodies, this means there has been a natural infection. It's been previously infected and it's treated, خلاص. If the surface is the only one that's positive, this means he's been vaccinated. For acute or chronic infection, you take a look at the IgM. If the IgM is positive, that's acute. If the IgM is negative, that's chronic infection. For hepatitis C, again, you need to take a look at the route of transmission, exactly similar to hepatitis B. Body fluids through IV drug abuse, sexual intercourse, so on and so forth. Now, the thing about hepatitis C, remember we said in hepatitis B, 90% of it resolved. In hepatitis C, 90% of it actually develop into chronic hepatitis. But it's worse. And most of it actually, or a couple of it could actually develop further into a hepatocellular carcinoma. But the issue about hepatitis C is its pathogenesis, or its certain properties. It has two main conditions, or two main proteins, the E1, E2, and then the RNA polymerase. Both are very highly variable, and the RNA polymerase itself leads to a lot of mutations. This is why it's very difficult to fight off hepatitis C itself. On microscopic features, you could forget this, and you could forget this, but do not forget C-ATOS. Remember that there is fat droplets in the liver in a hepatitis C infection. And it is very important that you remember. I thought I had a picture, but it's not there, unfortunately. But for diagnosis, first you're going to start with an antibody testing. You test if the patient has an antibody against hepatitis C. If the test is positive, you move on to an RNA testing. So you test if the patient is currently infected with an RNA assessment of that hepatitis C virus. If both are positive, this means this patient is positive for hepatitis C and they could transmit the infection. Finally, is for quantitative RNA testing. This is used for monitoring. This is for patients afterwards and to see the levels of RNA in their body, hepatitis C RNA in their body, and see how progressing or deprogressing the disease is. Right? Then you have hepatitis D and hepatitis E. Those are really straightforward. Hepatitis D is dependent on the hepatitis B surface antigen, and so it cannot infect alone. And there is two ways it could do this, either through an acute co-infection. So this essentially means the patient got infected with hepatitis D and hepatitis B at the same time. And that is diagnosed through an elevated IgM hepatitis D virus antibody and hepatitis B core antigen. Core antigen, if you remember, this means that this patient is 100% infected with the virus. Super infection means this patient already had an hepatitis B infection previously, and then the Delta came in and used the hepatitis B surface antigen to infect the body. Right? Finally, you have hepatitis E, very similar to hepatitis A virus. What you need to remember is that it is associated with places with heavy rain and floods. Again, it gets transmitted through contaminated food, fecal-oral route, and so on. And it is pretty serious in pregnant patients. Take care of hepatitis E in pregnant patients. Now, taking a look at autoimmune hepatitis. Autoimmune, from its name, the body starts attacking itself. Typically, anything autoimmune, you need to start thinking about females, but it typically affects females, and there is also other autoimmune diseases with it. How would you diagnose it? Remember the markers. For females specifically, or for adults specifically, remember anti-smooth muscle antibody. This is very important for autoimmune hepatitis. For pediatric populations, you could take a look at anti-LKM1. That's for autoimmune hepatitis in females and in adults. If the anti-smooth muscle is positive and it's in the question stem, that's 100% autoimmune hepatitis. Type on biopsy, there is something we refer to as interface hepatitis. So if you remember how the hexagonally shaped structures were, like this, they were joining together into sinusoid, and then you had the biliary tree or the bile canaliculi over here. So if you have inflammation in this region, this is what you refer to as periportal hepatitis. Interface hepatitis happens when the inflammation actually extends further and starts infecting all over the place. This is what we refer to as interface hepatitis. Finally, you have the plasma cell proliferation. From its name, you have plasma cells start proliferating around the place. And since it is autoimmune, how would you manage it? You'd give them steroids, and as if they're prime, you do immunosuppression. Okay? This is what I was referring to as interface hepatitis. So you can see here, hepatitis all over, and here are plasma cells, but this is plasma cell proliferation. Right? Right. Okay, now on to alcoholic liver disease. So for alcoholic liver disease, this patient, as we know, they drink a lot of alcohol. And how does this alcohol get metabolized? This alcohol goes to the liver and it gets metabolized by certain enzymes, you don't need to know the name, to acetaldehyde. Through this procedure, you have this happen. Right? You have a lot of NADH production and a lot of reactive oxygen species. Like, what does NADH do? NADH leads to stimulation of the enzymes that produce fat in your body. Right? So you have a lot of fat production. And it inhibits enzymes for fatty acid oxidation or fat breakdown. So this is the issue with high NADH. Another thing is reactive oxygen species, and as we know, reactive oxygen species cause a lot of cellular damage, and if they're in the liver, they cause irreversible damage to your hepatocytes. Right. Now we go on to acetaldehyde. Acetaldehyde, we leave it? No. Acetaldehyde itself is a reactive oxygen species, and it is categorized as a carcinogen, so it could lead to cancers if it accumulates for too long. Why does it lead to, or why is it categorized as a carcinogen? Because of a couple of things. Here are 5 reasons exactly found in your slides, to be honest. They could be easily asked about. And if I remember correctly, inhibition of DNA methylation was previously asked about. Those 5 things, formation of acetyl adducts and increased oxidative stress, both are very similar. Similarly, you have induction of Kupffer cells, which increases the oxidative stress. For 1, 2, and 3 are all oxidative stress related. 4, you have DNA inhibition of DNA methylation, and it could cause mutations and stuff. 5, you have impairing retinoid metabolism. Okay? So all those 5 together, all those 5 causes or effects of acetaldehyde on the body can lead to development of cancers. Okay? Like this is for alcoholic liver disease. Are we done? No, we have disease progression. What is disease progression? So how does the liver change according to the disease properties itself? First, you have steatosis. What is steatosis? You have fat buildup inside the liver. We already spoke about it once. After that, because of the reactive oxygen species, the hepatocellular damage, so on and so forth, you have hepatitis or inflammation of the liver itself. And finally, because of chronic inflammation on a longer period of time, you develop cirrhosis type. Now, for a patient with alcoholic liver disease, on early admission, how would the liver look like? Remember, on gross examination, the liver is large. So if you find it in a question stem, and wallah, this patient had a large liver, something like this or something like this, you'd have to keep alcoholic liver disease in your mind. Okay? Enlarged liver. But secondly, in steatosis, as you can see, there is fat accumulation, and this we refer to it as macrovesicular steatosis. So all of this white you can see over here is basically fat around or inside the liver itself. Right. And in hepatitis, what would happen? You'd have polymorphonuclear cell infiltration, and you can see here fat, and all of these are neutrophils. Neutrophils are surrounding those hepatocytes. Right? Right. And in here you can see those hyaline red structures. and those are referred to as Mallory hyaline bodies. And although they are not diagnostic, but they are also found in alcoholic liver disease. Finally, in cirrhosis, you'll find fibrosis and regenerative nodules. Simple. This is alcoholic liver disease in simple. Sorry. Yeah. So over here, we already spoke about how the transaminases change in alcoholic liver disease. You have twice as much transaminases as aspartate transaminase, twice as much than alanine transaminase. And how would you manage it? Here's the treatment. You abstain from alcohol, okay? Unless it did not reach cirrhosis. طيب. Fatty liver is very similar to alcoholic liver disease. يعني they both have a similar pathogenesis, but different cause. For alcoholic liver disease, it was because of alcohol. For fatty liver, it's because of a metabolic syndrome, either obesity, type 2 diabetes, hypertension. Any of those syndromes, يعني, it would lead to steatosis, which is fat accumulation. Then, because of the steatosis, it could be developed into hepatitis. And then on chronic, it would be cirrhosis. How would you manage those patients? You need to manage their metabolic syndrome. So you give them lifestyle modifications, they'd work more, they'd exercise more, so on, or lose weight. And you could also give them some medications. This is basically Ozempic, if you guys have heard of it. And how it works essentially, and really quickly, it causes increased insulin in your body. And Allahumma salli Muhammad, it causes as well, it stimulates your satiety center, so you feel full a lot of the time. Okay? This is Ozempic, or the generic name for it is semaglutide. Okay? Right. Now moving on to Wilson disease. What is Wilson disease? Wilson disease is a condition where you have a lot of copper accumulation inside the body. Why does this happen? It is an autosomal recessive condition, and it affects a certain mutation or a certain gene called the ATP7B, and there's a mutation there. Okay. So in normal conditions, the body deals with copper through two ways. It excretes it through bile, or it has ceruloplasmin, which binds copper. Okay? In this condition, you have this mutation that inhibits or decreases biliary excretion of copper and decreases the levels of ceruloplasmin. Both methods of controlling copper in your body are faulty, and this would lead to increased copper inside the liver. Okay? Now, as you can see over here, it typically affects less than 40 years of age. So if you get a patient that's more than 45, do not think of Wilson disease. It very commonly affects less than 40 years of age. Remember that. Yeah. Does it only affect the liver? No, it affects other structures, including the cornea, and it affects also the brain. It could cause neurological disorders, including, it could also even cause psychiatric disorders. Okay? So in the cornea, it causes something called Kaiser-Fleischer rings, and I'll show you a clearer image. And for neurological disorders, it could cause dysarthria, dystonia. Psychiatric could cause depression, anxiety. And how would you diagnose this over here? Diagnosis is through a low level of ceruloplasmin or an increased urinary copper. Okay? And how would you manage those patients? You give them some sort of copper chelator. The best one, or most commonly used one, is penicillamine. You could also give them oral zinc or do a liver transplant because they have a problem in their liver cells. Okay? Over here, you can see Kaiser-Fleischer ring. It is this brown color around the cornea. And then over here, you can see this is the inflammation in the hepatocellular or in the liver itself. This is the beginning of hepatocellular damage, right? Over here is another method of diagnosis through biopsy, and you can use something called a rhodamine stain. You can see this red region over here. All of those are copper accumulations inside hepatocytes. Okay? Now, similarly to Wilson disease, we have something called hemochromatosis. So Wilson disease, you have accumulation of copper. Hemochromatosis is where you have accumulation of iron. Now, again, it is a gene mutation in chromosome number 6. The gene is called HFE, right? Which essentially leads to decreased production of hepcidin. So in normal condition, what does hepcidin do? Hepcidin controls iron absorption or iron in the blood. It goes to certain transporters found in macrophages, found on the enterocytes, called ferroportin, and it inhibits ferroportin. What does ferroportin do? It causes iron to go into the blood. If you inhibit ferroportin, iron no longer goes into the blood. But this was the action of hepcidin. It would control that. So now, if you have no hepcidin, iron is freely going into the blood. The enterocytes will continuously absorb iron from the gut and release it to the blood. Absorb and release to the blood. And there is no control mechanism. So this is why iron starts accumulating. This is the genetic pathway. Now, there is another way, which is the non-genetic, through constant blood transfusion. Now, this typically happens in patients with anemia, specifically like beta thalassemias, where they need constant blood transfusions. And after a long period of time, they would develop as well hemochromatosis. Okay? Now, in contrast to Wilson disease, hemochromatosis occurs in more than 40 years of age. Okay? So this is a good way to differentiate between both as well. On histological stain, you can use Prussian blue, which looks like this. Simply put, blue cells or blue over the histology slide. خلاص, hemochromatosis. Okay? Now, in diagnosis, there is a triad. Think of three things. Think of bronze skin, diabetes mellitus, and of course, because it affects the liver, you have to think of cirrhosis. Finally, how would you manage it? Again, similar to Wilson disease, you have an iron chelator called penicillamine. And you could also do phlebotomy. So what is phlebotomy? Similarly to blood transfusion, you'd take blood out. Right? Over here as well, you can see this is a developed case of cirrhosis. So you can see the fibrosis, regenerative nodule, and blue. This indicates hemochromatosis. Now, alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is an enzyme used by the liver, and it functions by going to the lungs, and it inhibits something we call a neutrophil elastase. So it breaks down this neutrophil elastase. But if you think about it, it's called an elastase, so it breaks down elastic tissue. But if you think, the lungs now are getting, imagine the lungs as a rubber band, and you're pulling on that rubber band. It's elastic. Right? If you leave it, the rubber band, because of its elasticity, it would shrink back again. Right? Now, because of this elastase, you have continuous breaking down of the elastic tissue. And so if you pull on the lungs, if there is elastase activity, and you leave the lungs, you leave the rubber band, it won't shrink back again. So this is why alpha-1 antitrypsin is important. Now, if alpha-1 antitrypsin is deficient, elastase would continuously start breaking down the elastic tissue, and the lungs would not deflate properly. And this is what we refer to as a pan-acinar emphysema. Okay? You guys already took what emphysema is in CVP, but it's the exact same thing. Okay? Now, alpha-1 antitrypsin deficiency is caused by a mutation in a gene called SERPINA1 gene, and this leads to what? A misfolded protein. Where does this misfolded protein start accumulating? Because it's synthesized in the liver, it gets accumulated in the liver, and this would eventually lead to liver cirrhosis and so on and so forth. Now, a characteristic finding always found or mostly found in questions is a past positive granule. If there is a past positive granule and there are signs of cirrhosis and signs of emphysema, you could directly go to alpha-1 antitrypsin as your main differential. And here are a couple of images. Here are past positive granules accumulating inside hepatocytes, and you can say that this patient has alpha-1 antitrypsin deficiency. Okay. Now on to biliary tree pathologies. Let's start with cholelithiasis. So cholelithiasis essentially means gallstone. That didn't cause any inflammation or anything, just a gallstone. Now we need to remember the risk factors. They're very important. I remember we got asked about like a couple of, it was like lists 5 risk factors or something, or 3-4 risk factors. If I remember the risk factors, 5 Fs: female, fat, fertile, 40, fair. 5 risk factors, try to memorize them, come day of exam, write them as is. Right? That's cholelithiasis. Then you have a couple of terminologies that you need to refer two, starting with biliary colic. Biliary colic just means, wallah, you have right upper quadrant pain, postprandial, right upper quadrant pain, and postprandial, usually after eating. Right? Acute cholecystitis is you have right upper quadrant pain, and because it's an inflammation, you have fever. So right upper quadrant pain and fever. There is no jaundice, right? Choledecholelithiasis essentially means it's a gallstone affecting or blocking the common bile duct, right? So all the bile from the gallstone or from the gallbladder or the liver is unable to pass through, right? But this is choledecholelithiasis. This is why they have right upper quadrant pain and jaundice, because bile cannot exit the body. For acute cholangitis, it's when you have all three. Right upper quadrant pain, fever, and jaundice. And this typically is referred to as Charcot's triad. Right? Now, for cholecystitis, you have three types of cholecystitis. Either you have acute calculous cholecystitis. It's where you have a gallstone blocking the cystic duct. So the liver can still release bilirubin into the common bile duct, but the gallbladder is blocked by the gallstone. So this is acute calculous cholecystitis. They present with right upper quadrant pain and fever. And for acute acalculous cholecystitis, you need to remember it typically happens, or it's not, it always happens in critically ill patients. But read the question carefully. If it happens, if they get a critically ill patient, an ICU patient, a motor vehicle accident, a trauma, any sort of those patients, you need to and they started presenting with right upper quadrant pain and a fever, that's acute acalculous cholecystitis. Why does it happen? It happens because of ischemia, less blood flow to the gallbladder, there is biliary stasis, there is sludge, there is infection. All of those would lead to an inflammation of the gallbladder and lead to acute acalculous cholecystitis. But then you have chronic cholecystitis. This is where you have continuous or repeated damage or irritation to the gallbladder wall. And this would eventually result in hyperplasia of the hyperplasia of the cells, and it would lead to increased mucus production. Could lead to chronic cholecystitis. As you mentioned, acute calculous cholecystitis, it presents with right upper quadrant pain. It typically happens after fatty meals, and there is fever. Right? Positive Murphy sign. So Murphy sign is important to know. How it gets triggered. So I typically ask the patient to expire all their air. They expire, and you put your hand under their lowest rib or intercostal rib on their right side. Okay? And then you ask them to take a deep inspiration. Once they inspire, the inflamed gallbladder would hit your finger, and once that happens, you would stop. So it is cessation of breathing after you palpate that region over there. Okay? So this is a positive Murphy sign. How would you diagnose those patients? Your initial exam is always an ultrasound. So you start with an ultrasound, and what will you find on ultrasound? You will find this, an increased wall thickness. So here is normal bladder wall. Here is a thick bladder wall. Okay? And then you'll also find Murphy sign again. So when you put the probe over here, the patient will feel pain, and that's a positive Murphy sign. But let's say your ultrasound findings were inconclusive. What would you do? You do a HIDA scan. A HIDA scan essentially introduces a radioactive substance into your blood, and this substance goes to the liver, it passes through and gets into the hepatocyte and then gets released into the bile. Normally, you should see this. The gallbladder should show. There should be a gallbladder. If there is a filling defect, if the gallbladder does not appear, this means there has been an obstruction, and it is most likely because of the other signs. It is most likely an acute calculous cholecystitis. Right? So this is this is how we could diagnose acute calculous cholecystitis. Now, moving on. Now, there are three possibilities for the gallstone. Either the gallstone goes back into the gallbladder and the inflammation subsides. This is the best case scenario. Or it moves down to the common bile duct. And we already mentioned how this is referred to as choledecholelithiasis. When you have obstruction of the common bile duct, you'd have right upper quadrant pain and jaundice, or it could go and block the pancreatic duct. So if it blocks the pancreatic duct, there would be retrograde movement of pancreatic enzymes, and this would lead to pancreatitis. Okay? Right. Now the third scenario, okay, let's take a look at cholelithiasis really quickly. So for cholelithiasis, you could diagnose it using an MRCP, and it may lead to acute cholangitis. We already mentioned what acute cholangitis is. It is fever, right upper quadrant pain, and you'd have jaundice as well. And it typically happens because of an obstruction. What happened? Okay. So taking a look at cholelithiasis, you could diagnose it using an MRCP. And it, as we mentioned, it may lead to acute cholangitis. So if you have this obstruction, you'd have bile accumulating above, and this could lead to an infection over there. And this is an acute cholangitis, where you have right upper quadrant pain, you have fever, and you have jaundice because bile can no longer be excreted. If you add to it confusion and there's hypotension, you'd start thinking about Raynaud's pentathlon. Now, this is more serious. Most commonly caused by E. coli, Klebsiella, and Enterococci. Remember the organisms. Finally, regarding diagnosis, again, remember the first line or initial is always an ultrasound. And then you can do an ERCP where you can see the obstruction and even manage it or remove that gallstone. So this is why I have here ERCP also for management. Okay? Right. Now, we discussed how the first two, inflammation subsides and could cause cholelithiasis or gallstone pancreatitis. The third scenario is if it gets more stuck and it does not resolve, it leads to more inflammation, more necrosis, it could lead to the complications. So over here, you'll take a look at the complications, starting with gangrenous cholecystitis. So this essentially means there has been necrosis of the gallbladder wall, and this is gangrenous cholecystitis. Once necrosis happens, the wall is weaker, and this can lead to perforation. Right? Secondly, it could lead to an emphysematous gallbladder, which essentially means because of the obstruction and the inflammation and the bile piling up inside the gallbladder, this can lead to an infection developing. So an infection usually by gram-negative, gas-producing gram-negative organisms. And emphysematous because there is air entering into the gallbladder walls. Okay? Right. Finally, you could have cholecystoenteric fistula, which is basically a connection between, imagine over here in this picture, a connection between the gallbladder wall and the small intestine. So the gallstones are able to escape and enter into the intestine, and this can lead eventually to something we refer to as a gallstone ileus, and it is characterized by Rigler's triad. What is Rigler's triad? It is when you have three things: small bowel obstruction. So on CT or an X-ray, you'd find distended bowel loops. So this distended bowel loops indicates small bowel obstruction. Two, there is pneumobilia. So pneumo is air, bilia in the biliary tree. So over here, you can see air entering into the biliary tree. Three is an ectopic stone. Over here, you can see a very well-demarcated ectopic stone. And so all those three together indicate, in Allah, there has been a fistula connecting the gallbladder to the intestines, and there has been a gallstone ileus. Type. How would you rule out these complications of acute calculus cholecystitis? You do a CT scan. Do a CT scan to rule it out. So if you go back to our workup, first you do an ultrasound to diagnose it. Then you would do, if the ultrasound was not enough or was not conclusive, you do a HIDA scan. And then to avoid complications, you would add on a CT scan to rule out any of those. Like over here on the right, really quickly, we could take a look at Merizzi syndrome, which is a gallstone obstructing at the neck of the gallbladder. And if you can see here, there is an obstruction at the common bile duct. So if you can imagine it with me, it could probably cause symptoms very similar to cholelithiasis, which is right upper quadrant pain and jaundice, because bile can no longer exit the or exit the body. Yeah. But then we have porcine bladder, which is a complication of chronic cholecystitis. So we said because of chronic cholecystitis, there is continuous inflammation, fibrosis, and thickness of the gallbladder wall. And this is eventually after a while, it will develop or there could happen what we refer to as dystrophic calcification of the gallbladder wall. There will be calcification in the gallbladder wall, and this is what we refer to as porcine bladder. Now, the issue with porcine bladder is that it can develop into a gallbladder cancer, and this is why the management of porcine bladder is a prophylactic cholecystectomy. Right. Now on to secondary biliary cirrhosis. On secondary biliary cirrhosis, there has been an obstruction of the extrahepatic biliary tree. So the biliary tree outside the liver, there is an obstruction, whether it's through cholestasis, cancer, and this obstruction eventually leads to bile buildup. The bile will go back up and into the liver, and because bile is very toxic as well, it would lead to the inflammation, and across a longer period, hepatitis, cirrhosis. You know the pattern now. Like, if you guys can, please remember the causes. The causes in adults, as you mentioned, you can have a cholelithiasis or a gallstone, and this is the most common cause in adults. Now, it could be because of a malignancy, usually because of a cholangiocarcinoma or an adenocarcinoma of the pancreas. Those could also cause an obstruction. Like in children, biliary atresia is a condition where the child is born with a defect in the biliary tree. So the biliary tree are not well developed. The liver cannot release or excrete the bile, and this would lead to, again, bile backing up. It could lead to hepatitis and cirrhosis. Secondly, you have cystic fibrosis. You have choledochal cysts. Choledochal cysts are cysts or dilatations in the biliary wall, and again, bile would accumulate there, and it would start building up and could lead to this condition or secondary biliary cirrhosis. Finally, congenital paucity essentially means that now you have few bile ducts. But even though you have bile ducts, it's similar to biliary atresia. You have bile ducts here, but it's few. You cannot efficiently release or excrete all the bile in the body. And this is how it would look like. On gross morphology, it is very hard and yellow-green. This is the liver. And over here, you can see this is a more developed case. You can see the regenerative nodules and the fibrosis surrounding. Then you have primary biliary cirrhosis. Similar to secondary biliary cirrhosis, so the concept is you cannot excrete the bile, and the bile starts backing up. But in primary biliary cirrhosis, the cause is an autoimmune destruction. Over here, you know the cause. It happens either because of one of those things. In primary biliary cirrhosis, the cause is unknown, and they said in Wallah it is an autoimmune destruction. It typically affects, like we said, autoimmune, always think about females. So it typically affects females. It could cause all of those symptoms, xanthomas, steatorias, malabsorptions, all because bile acid is not being released, all the functions of bile. Hallmark, this is very important to remember, anti-mitochondrial antibodies. But remember, anti-smooth antibodies for autoimmune hepatitis, anti-mitochondrial antibodies for primary biliary cirrhosis. How would you manage those patients? Again, because they are unable to release the bile from the body, you could give them a molecule that helps release that bile, which is also the oxalic acid. If that doesn't work, you could do a liver transplant and fix their autoimmune destruction. But on microscopic exam, this is how it would look like. طبعا it looks like a granuloma. But remember, this is the typical appearance of primary biliary cirrhosis. You always have a granuloma. Secondly, you could have a few ducts or ductopenia because you have autoimmune destruction of those biliary tree structures. You have portal inflammation. Remember when we mentioned how around the portal triad there is portal inflammation. If it is more diffuse, this is interface hepatitis. Right? And then you have portal fibrosis. But if you can remember granuloma and a few or ductopenia, it would be enough for the microscopic features of primary biliary cirrhosis. But primary sclerosing cholangitis. So if you could go back to the name, sclerosing essentially means blockage or constrictions. But it is essentially is a fibrosis and stricturing with dilations of the unaffected portion. So I have areas where it's patent and areas where there is strictures, areas where it's patent and areas where it's strictures. But if you could imagine with me, طبعا I'm not the best at drawing over here, but it would sort of look like a bead of pearl appearance. And like we mentioned, again, bile would not be able to be efficiently released or excreted, and it will start building back, lead to chronic cholestasis, and it will lead to hepatitis, cirrhosis, and so on. The association over here is ulcerative colitis, and there is a P-ANCA positive. So ulcerative colitis is also P-ANCA positive. Those patients with ulcerative colitis more or less have an increased likelihood of developing primary sclerosing cholangitis. And unlike primary biliary cirrhosis, you have middle-aged men are typically affected over here. All right. Okay, I thought we were done. This one more thing is how it looks like microscopically. Over here, you can see an onion skin appearance, but this is very typical of primary sclerosing cholangitis. And you can sort of imagine how these strictures start forming. And on this right side, again, you guys should be experts of this now. This is the typical look of cirrhosis. So you have fibrosis and regenerative nodules. And yeah, also you can sort of see over here, if you could focus a little, you could say, no, this is an onion skin appearance as well. All right. Now, moving on to liver and biliary tree tumor. Okay, so for benign liver masses, I need you guys to remember 4 masses. You have cavernous hemangioma. Always remember, hemangioma is a tumor of endothelial cells. Cavernous hemangioma is a benign mass of endothelial cells. We're going to take out all their images soon as well. Then you have focal nodular hyperplasia. There is, from its name, there is hyperplastic hepatocytes, and it is nodular. The characteristic sign is central stellate scar. It typically affects women of reproductive age. It could get confusing with the next one because it also affects women of reproductive age. Thus, the way you could differentiate it is central stellate scar. It's very diagnostic of it. Then you have hepatic adenomas. So for hepatic adenomas, they are masses that happen in women in childbearing age. And specifically, they are taking oral contraceptives. And if you stop that oral contraceptive, the adenoma will regress on its own. Finally, you have dysplastic nodules. Typically, if you guys remember, when it comes to the cirrhosis, you have, for cirrhosis, you have fibrosis, bridging fibrosis, and regenerative nodules. Those regenerative nodules are typically 0.5 to 0.7 centimeters. If they reach to 1 to 2 centimeters, then this is a large cirrhotic nodule, and it is referred to as a dysplastic nodule. And there is a chance that it could actually develop into a hepatocellular carcinoma. Right. So benign liver masses, as we said, over here you can see the cavernous hemangioma. These are endothelial cells, and the pink inside is the stroma. So if you see this image anywhere, not only in liver disorders, anywhere in general in the body, forever from now till your medical career is done, always think about hemangiomas, cavernous hemangiomas. Then you have this very typical central stellate scar. This is focal nodular hyperplasia. You can take a look over at the hepatocyte hyperplasia as well over here. It typically does not follow the same organizational structure as that of a regular hepatocyte. Thus, so that you don't confuse, always remember central stellate is focal nodular hyperplasia. Also happens in women in reproductive age. Then you have your hepatic adenoma. As you can see, this hepatic adenoma. Now, this hepatic adenoma is kind of dangerous because it could lead to, it could rupture and could lead to life-threatening hemorrhage. And another thing, even though is that it is considered a benign mass, there is a type that could actually transform into a hepatocellular carcinoma. So there are 4 types you can remember. You have HNF1 alpha inactivated hepatocellular adenomas. There is no risk of malignancy over here, and it happens to women within childbearing age who are taking contraceptives. Beta-catenin activated hepatocellular adenomas, those are at high risk of malignancy. It happens in women and men. Then you have inflammatory hepatocellular adenomas. This has a low risk of malignancy. And then finally, you have unclassified adenomas. Right. And over here, you can see that this plastic nodule, compared to all the nodules, this is a very cirrhotic liver. All the other nodules are typically smaller in size, but this one is taking a larger size. So this is a dysplastic nodule that has a chance of transforming into hepatocellular carcinoma. Like for malignant liver masses, you have 4 to remember. Now, the most common malignant liver mass is usually malignant. So it is usually a secondary tumor from either the colon, typically because specifically the GI tract and the colon, because the portal circulation goes all the way to the liver, the lungs, and the breast. So this is the most common. But secondly, you have the hepatocellular carcinoma. Thirdly, you have the angiosarcoma. And something to remember is if there is any mention in that patient in the question stem has been exposed to arsenic and vinyl chloride during his life, then you should think right away for angiosarcoma. Then you have hepatoblastoma. This typically affects children. I doubt you'll get asked about it. طيب. Now, for hepatocellular carcinoma, it typically affects 2 types of people. Either it affects an Asian who is young, 20 to 40 years. Those people are non-cirrhotic and they have a hepatitis B positive, and they're usually exposed to aflatoxin. Aflatoxin is very important. And how we could find that from the question stem is if they mention anywhere that this patient has been exposed to moldy grain and peanuts. Now, the other types of patients that could get this hepatocellular carcinoma are Eastern patients who are typically elderly. They are cirrhotic. They have hepatitis C virus. And all 3 together, Eastern and more likely hepatocellular carcinoma. But what is the cause of hepatocellular carcinoma? Anything that causes liver cirrhosis and aflatoxins. Aflatoxins is pretty high yield. Okay? Right. In labs, remember, there is elevated alpha-fetoprotein. On gross and microscopic, you'll find bile material, and microscopic specifically, you'll find acidophilic hyaline inclusions. It has a very bad prognosis. And for management of any cancer, you need to remember that you start by doing staging, and staging through CT, MRI, or PET-CT. That's usually for hepatocellular carcinomas, you use CT or MRI, you stage the tumor, and afterwards you could move to the treatment. So for treatment of hepatocellular carcinoma, either you can resect it if it's a single mass, and if it's single, resect it. You can do liver transplantation, completely remove the liver, and you can do radio or chemotherapy, right? Depending all on the stage type. Over here, you can see yellow, which is sort of representing the bile, and then as well, yellow bile with hyaline inclusions, acidophilic hyaline inclusions. All of those are signs of hepatocellular malignancy. Right? Then you have gallbladder biliary disorder. So 2 malignancies you need to remember, gallbladder carcinoma and cholangiocarcinoma. Gallbladder carcinoma, from its name, there is cancer in the gallbladder. It's usually an exophytic mass or a protruding mass inside the gallbladder. It typically affects older women. And the risk factors you already kind of spoke about, low chronic cholecystitis, porcelain bladder. You're just going to have to add infection by Salmonella typhi. I think now, if I recall actually correctly, the SAQ that we got was a patient, what are the risk factors for gallbladder carcinoma? You could write in older age, you could write female as a gender, then chronic cholelithiasis, porcelain bladder, salmonella infection, all of those are risk factors for gallbladder carcinoma. It is usually an adenocarcinoma, and there is a 5-year survival from onset of diagnosis. Over here, I've attached the T and M, the T staging. To keep it simple, T1 is usually within the mucosa still, so within the lamina propria muscular layer. Then when it invades the underlying connective tissue and the submucosa, then that's where that's T2. When it reaches the serosa, that's T3, and it starts invading the other surrounding organs or the blood vessels, that's T4. Okay? Now, you have finally cholangiocarcinoma. cholangiocarcinoma comes from cholangiocytes. What are cholangiocytes? They are the cells that line the biliary tree. Okay? Epidemiology, again, it affects elderly population. Risk factors, remember, primary sclerosing cholangitis, and it could also be as a result of an infection by this infection over here. But again, it's adenocarcinoma. It typically appears whitish tumor. There's a picture, Saraha, I forgot to include, where there is like a whitish mass over here. This would be a cholangiocarcinoma. Diagnosis is through an MRI or an endoscopic ultrasound. Okay. Now, finally, for some miscellaneous masses, they are benign masses such as liver abscesses and hydatid cysts. So the epidemiology, typically it affects immunocompromised, could be young or old. Honestly, this immunocompromised could be a little misleading because not all of those patients are actually immunocompromised. Secondly, it could affect, it typically affects the right lobe of the lung. And thirdly, you could diagnose it through X-ray. That's not typically used. What's most commonly used is ultrasound and CT, where you could actually visualize the mass, the abscess or cyst. Now, there are three things you keep in mind: amoebic abscesses, pyogenic abscesses, or hydatid cysts. For amoebic abscesses, the etiological agent is typically an Entamoeba histolytica. For pyogenic abscesses, the cause is either an E. coli or Klebsiella, which are gram-negatives. There are some gram-positive strep species as well. And for hydatid cysts, remember Echinococcus granulosus, and more importantly, remember its association with sheep. Okay. Right. Now, when it comes to the management for pyogenic abscesses, you typically drain and do antibiotics or give antibiotics. You do not drain amoebic abscesses. You typically start them on metronidazole, and it should resolve on its own. For hydatid cyst, water lily sign is actually a radiographic sign, and it is characteristic of hydatid cyst. You could have a big cyst like this, and there is many multiple it looks like a lily hydatid cyst in the liver. And the treatment would be albendazole or mebendazole. And yeah, that would be it for our discussion. One thing that I've just remembered, and I forgot to mention, it was in regards with hepatic encephalopathy. So in hepatic encephalopathy, I don't think I've mentioned the management. So remember, if it ever comes to you, management of hepatic encephalopathy actually is lactulose. Okay, so you give this patient lactulose. What's the mechanism of action of lactulose? It absorbs the ammonia produced by bacteria in the intestines and allows its excretion. So this way, you're releasing the ammonia from the body. Okay? And yeah, that would be it for our discussion. I hope that you guys find it beneficial. If you guys have any questions, please feel free to text me whenever you want. Let me actually share with you the, so this is a feedback. And if you have any questions, please feel free to text me whenever you want. And yeah, best of luck on your exam. Allah yuwaffiqkum ya Rabb. Wa assalamu alaikum.